So welcome. My name is Pam Edgar. I'm the Director of Education at CaringKind. We're thrilled to welcome you to the benefits of LGBTQ plus affirming dementia care. We have two acclaimed speakers today. First, we have Dr. Tara McKay. She is a nationally recognized expert in the field of LGBTQ plus population health, policy, and aging. She is the co-founder and director of the Vanderbilt LGBTQ plus Policy Lab, which was recognized by the National Institutes of Health for advancing diversity, equity, inclusion, and access in health research in 2024. Her research examines the social and policy contexts that shape health over the life course, primarily among LGBTQ plus populations in the US and African contexts. In 2024, Dr. McKay received the Vanderbilt University Chancellor's Award for research on equity, diversity, and inclusion. Her work has been cited over 2,300 times and engaged with by academic colleagues writing from institutions in over 36 countries. And she was recently featured on the PBS Aging Matters series, and PBS also produced a short special focusing on the findings of her research. So we're very thrilled to have you with us, Dr. McKay. And we also are thrilled to welcome Dr. Nik Lampe. Dr. Lampe is an assistant professor in the Department of Mental Health Law and Policy and affiliated faculty in the School of Aging Studies at the University of South Florida. Their research program examines behavioral health disparities amongst LGBTQIA plus aging populations, as well as the health and well-being of older adults living with dementia and their family care partners. Dr. Lampe also serves as a research consultant for the African American Alzheimer's Caregiving Training and Support Project 2, ACTS2, a Florida-based program that provides free, evidence-informed skill building and support services to Black dementia caregivers. They are currently leading a 3-year research project funded by the Alzheimer's Association, which investigates risk and protective factors for dementia among LGBTQ plus seniors. In 2025, Dr. Lampe received the LGBTQ plus Older Adults and Aging Scholars Award from AARP and the Northwestern University Institute for Sexual and Gender Minority Health and Well-Being. Their research on LGBTQ plus aging was recently featured by WUSF Public Media, Tampa Bay's NPR affiliate. So welcome. We are so happy to have you with us. I am going to stop sharing my screen, okay? And you all can take over and take it away.
Wonderful. Thank you so much, Pam. Thank you all for joining us. I am really thrilled to be here today to share what we have for you. And a lot of this is based on work that Dr. Lampe and I have been conducting over the last several years. We have nothing to disclose in terms of conflicts of interest. We do have a couple learning objectives for you today. Our first objective is really to help you understand why we care about this population, what the differences here might be, really to understand the unique life experiences, the historical context, the different health trajectories and support needs of LGBTQ older adults. In addition, we would like, in terms of our second objective, to actually start to look at the clinical and cultural competencies that we'd like to see enhanced in care in order to provide respectful, inclusive, affirming care for LGBTQ seniors across healthcare settings, especially in dementia care settings. And then finally, our third objective, which will be presented by Dr. Lampe, is to help identify key concerns and strategies for care partners that are supporting LGBTQ older adults. That includes navigating things like family dynamics, chosen families, access to affirming services, and so on. So to start, we'll be kind of giving you an overview of this population, trying to think about the different ways that especially folks who are kind of currently LGBTQ older adults, so the current generation of older LGBTQ adults, what kinds of issues they might have experienced over the life course, other kinds of support needs they have, their current health trajectories that we have good information on in the research space. So broadly, across the life course, LGBTQ people experience earlier and more severe disease. So we see persistent kind of disparities in a lot of different health areas. In younger people, this tends to be in the mental health space. As we age into midlife, we see disparities or differences grow in the prevalence and severity of chronic health conditions like obesity, diabetes, cardiovascular risk. And then in later life, we tend to see differences in what's called multiple morbidity or having multiple diseases at the same time. And we see evidence that's suggestive of disparities in aging related diseases like Alzheimer's and dementia. And I say suggestive here because there's limited evidence. We have kind of just these few studies so far, but what the available information kind of tends to show is that there are differences in the severity and age of onset and in the prevalence of issues like cognitive impairment, mild cognitive impairment, Alzheimer's, and other vascular related cognitive dementias. We also see substantial disparities in cancer risk, especially things like cervical cancers, breast cancers, lung cancers, prostate cancers, skin cancers, oral cancers, colorectal cancers, and oropharyngeal cancers in the throat. We also see greater likelihood of cancer recurrence. So a study was recently done with sexual minority women, that's gay and bisexual women. And that study found that these women had a 3 times higher recurrence of breast cancer after treatment. So after they had concluded treatment, they were 3 times more likely to have a recurrence of that same cancer compared to heterosexual women, adjusting for lots of other characteristics like age and cancer stage and genetic profile of the cancer and so on. And then in addition here, we tend to see higher mortality for certain cancers among sexual minority and gender minority folks. This varies by population, it varies by the cancer that we're talking about, but there does seem to be evidence in that space as well. And then a recent study was conducted with the nurses study that has kind of followed folks who were in midlife in the 1990s through to now, and seen that there's also earlier all-cause mortality among sexual minority women in the cohort of nurses that they followed. This is one of the best studies that we have for looking at differences in mortality because it's what's called a prospective cohort. It follows people over time. It's not kind of getting them, recruiting them based on a certain disease profile or having them opt into a study because they're healthy, right? It's following people over time who are all about the same at the time of the start. In terms of the disparities in cognition and cognitive decline, some of the data that we do have, I wanted to share with you specifically. So we see that sexual minority adults report higher prevalence and more severe cognitive decline across a range of studies. Many of these studies are with clinical populations, or we kind of have like a single question in nationally representative studies that's trying to gauge subjective cognitive impairment. Some of the work that we've been able to do with these national studies that have that single question that are representative of the population is show that there is actually a substantial difference here. So for sexual minority women versus heterosexual women, we see a 6 percentage point difference in the prevalence of subjective cognitive decline, so themselves rating their own cognition, and that difference is also present for sexual minority men. So again, here we're talking about gay and bisexual men compared to heterosexual men. And that difference is 5 percentage points. So 15% are reporting that they are experiencing conditions or symptoms similar to cognitive decline compared to 10% for heterosexual men. And they also report in this context that that impairment is impacting their ability to live independently. So surveys very often ask questions about whether or not you can bathe yourself, feed yourself, use the bathroom independently, and so on, or pay bills, these kinds of independent activities of daily living. And what we see is that not only do we see higher levels of this impairment among sexual minority men and women at the same age, but that those folks who are experiencing subjective cognitive decline are also more likely to report these impairments in terms of their independent activities of daily living. And so one thing we were interested in knowing is whether or not they actually get more help for these activities, right? So if they're experiencing more severe cognitive decline, if they are experiencing more impacts on their ability to live independently, what's the next kind of piece that they need, which is what's that care or support structure look like? And we find, especially for sexual minority women, that despite this higher need for help with independent activities, and that higher prevalence of subjective cognitive decline, a large number of sexual minority women, in our case, it was about a third of sexual minority women reporting these issues, didn't get help or didn't get the help that they needed adequately to address their concerns and ability to live independently. So just to sum up that slide, we see higher prevalence, more severe symptomology, and less help for sexual minority women in particular in this space. You might be asking, why is this all happening? Why do we see this specifically for this population? A lot of the literature points to increased stress exposure over the life course. So over the course of a LGBTQ person's life, they're very often living in an environment where they are a kind of minority person who is easily identifiable, or at least is concerned that they might be so, and then is like vigilant about how they present themselves in different spaces. They may also very blatantly experience discrimination, victimization, hostility from other folks. They might experience rejection from their families. They might experience discrimination at work. And so there are a number of kinds of experiences that just increase the kinds of stressors that LGBTQ people face throughout their life. These stressors have lots of impacts on the body. So one thing that I've been focused on in the aging space is looking at sleep disruption. Sleep is a really critical kind of way that your body repairs itself, especially in the brain. And so we see a lot of links between sleep disruption and cognitive impairment. And minority stressors, or these other kinds of stressors that LGBTQ people experience over their life course, very often not only have that immediate stress kind of response where you kind of have your heart rate increase, your breathing rate increase, your cortisol levels increase, but that lingers, right? Those are all kind of alertness kinds of things that stay with you and keep you from falling asleep. And so that alertness also has that impact on sleep. Those stress exposures have that impact on sleep, which can kind of exacerbate the role of these experiences on cognitive decline over time. In addition, we know that chronic exposure to stress really just isn't good for your body. It starts breaking down tissues. Your body might also respond by like changing in different ways in order to respond to that high level of stress and the hormones that are expressed persistently. And so one of the ways that we've also been looking at this is by examining at the molecular level of your DNA, how old is your body? So your body is chronologically, let's say 45 years old, 65 years old, but your DNA and the way that it's replicating, right, can be linked to what we call a biological age. So we can sample your tissue, extract your DNA, and run some other algorithms on this in order to basically estimate your biological age, the age of your body. And when we do that, we find that LGBTQ people, on average, are aging at a faster rate than heterosexual people, in large part when they experience these substantial exposures to stressors, especially over time, so over many years or decades. And when we see that, we also see that in tandem with metabolic dysfunction, insulin resistance, vascular changes, various things that we now know are contributing to cognitive decline just generally in all people biologically. There are two other spaces that, like in terms of physiology, might also be contributing here. These two spaces are much less understood, I would say, in terms of the science and the literature that we have on it, but there are concerns about HIV and its relation to cognitive changes in the brain, or structural changes in the brain that might lead to cognitive impairment. And then especially the older, earliest HIV treatments have been examined for some toxicity related effects leading to cognitive changes and impairment, especially over prolonged use. In the other area, this bullet 7 that you see here, there's an increasing interest in hormone replacement therapy for both testosterone and estrogen for transgender people in terms of its role in cognitive capacity in later life. So we know that in cisgender women, estrogen can also often have a protective effect. Is that creating a protective effect for transgender women as well who are taking estrogen? Are there concerns about taking testosterone for biologically female folks or born female folks? Are there concerns about testosterone depletion in other transgender folks who might be taking estrogen, et cetera? These are all questions that are out there that science has not yet answered, but they're concerns that people are interested in knowing about, especially as more and more folks identify as trans and are using hormone replacement therapy as they age. In addition to some of the stress response that we see in the body, there are lots of other things that might create differences for the LGBTQ population in their relationship with healthcare. So I'll focus here on discrimination in the healthcare setting. And we know that up to 1/3 of LGBTQ Americans avoid seeing a doctor due to fear of discrimination. And we know this from surveys that have been conducted. And in this context, in the medical care context, many LGBTQ people aren't out to their provider. That might be for a range of reasons, right? They're concerned about confidentiality. Is this going to be shared? Is this going to be put into my record? Am I going to be mistreated for this, in relation to this information? Or they might feel that this is actually just not relevant information that this provider needs to know in order to treat me fully. In this context, there's a range of literature looking at what non-disclosure means for the healthcare encounter. So non-disclosure of LGBTQ status. And what this literature tends to find is that not telling a provider that the patient not telling the provider that they're LGBTQ often leads to some inattention to specific healthcare needs. This literature is focused a lot on sexual healthcare needs, but I think there's a range of other areas that we could look into that would also kind of be concerns where non-disclosure would be especially impactful. In addition, they show that there are often misdiagnostic screenings and vaccinations. Again, this has often been in the context of sexual health care, but we can think about a range of other areas where this might also be problematic. And then finally, they do find broadly that there's a higher unmet medical need among folks who just aren't out to their provider, which might come with some concerns about just spending time at the doctor or being open about what concerns are broadly, or concerns about how the physician or the team at that practice is going to respond to some of that information. As I mentioned, non-disclosure is certainly an issue, but even when LGBTQ people are out to their provider, sometimes the care that they receive is inadequate or inappropriate. So there's research showing that sexual minority women, so gay, lesbian, or bisexual women, are significantly less likely to be offered a pap test than heterosexual women, due to assumptions about who they're having sex with or sexual risk here. Transgender people with prostates are less likely to get screened compared to cisgender gay men and heterosexual men. And gay and bisexual men who don't disclose their sexual orientation to their provider are less likely to receive appropriate vaccines like an HPV vaccine. Again, these are primarily in the sexual health space, but that's just where the literature is. And so we don't have a lot of a broader science base here to look at other spaces, even though I expect that there are other areas that are impacted similarly in healthcare. When patients feel that the care that they're not receiving is not affirming, or they anticipate that it's less likely to be affirming, there are substantial impacts. So what we actually see is less patient-centered care and patient involvement in medical decision-making, so withdrawal from engagement in that space. A greater burden of comorbidities at diagnosis. This means that people come in with more conditions or diseases or symptoms that need managing all at once because maybe they've delayed that care, they've had concerns about engaging that care due to past experiences or anticipated discrimination that they might experience in this setting. They also tend to see reduced partner involvement in care. So care partners are less likely to come to appointments. They're less likely to be involved in decision making. And this can lead to higher social isolation during treatment. The main kind of literature base that's here is around cancer care. And so they find in this context, when care is less affirming, or when patients view their provider as less affirming, they're much more likely to kind of have problems during the treatment experience. They're much more likely to be physically inactive during their treatment, have more complications, have more depression and mental health issues throughout their treatment, use substances, be more isolated, and not have those care partners available while they're kind of managing their medical care. Beyond the healthcare system, there are certainly additional challenges that might contribute to poor health outcomes for LGBTQ populations. So I'm also in a health policy department, and we study things like structural barriers. This might mean like lower rates of health insurance among LGBTQ people because of job discrimination or lower rates of marriage. In the United States, people often gain access to health insurance through marriage. And so when you have kind of a group of folks that is specifically excluded from marriage for decades, you end up also with this kind of spillover effect of them also tending to have lower levels of health insurance access. When people don't have health insurance, they don't go see the doctor. So they miss screenings, they have later initial presentations for care. That's true of most people who don't have insurance. But it's especially true for LGBT people because they're disproportionately more likely to lack health insurance. Additionally, I'm in Tennessee right now, and we've seen laws that allow providers to openly discriminate against LGBTQ people and other minority populations. So, for example, we have a denial of service law that's applicable in the mental health counseling space. A few other states have this also in the medical space. And so in these states, healthcare providers are allowed to say, I don't want to treat that person, and deny service to the patient outside of emergency care, right? And so in those contexts, we know there's big impacts on how people engage with healthcare and their anticipation of discrimination in those settings. Additionally, in some groups within the LGBTQ population, we see higher behavioral risk factors for certain diseases, like smoking, for example, that haven't really been adequately addressed by prevention, intervention, or screening. And then, as is very common, especially in certain healthcare spaces, we see folks who see different providers for different issues. among the LGBTQ population. So you might see someone for your endocrinology space, you might see someone for sexual health, you might see someone else for your internist kind of needs. And this leads to a lot of care fragmentation. The physicians may not even be within the same system. They might not have access to the same records. They might not know what medications or vaccinations or other things might be relevant to your care that have been done by another provider or not done by another provider. And so that can be really challenging and create poorer outcomes in healthcare as well. The last thing that I'll talk about in terms of kind of some of this cohort of currently older LGBTQ folks is that they're often referred to as the first out generation. And that comes with, its amazing benefits and applause and celebration, as well as some of the challenges, right? So I often hear from participants in my studies that they really had limited or no models for aging. And that, being 65 or 70 or even 80 is now this really unexpected outcome that they didn't plan for. So I have one quote here from a participant that has relayed to me, I never expected to live past 40 and now I'm 60. What do I do? What is life supposed to look like? What's the route? How do I even do this? And then in this space as well, I would say that the targeted LGBTQ healthcare and aging and caretaking supports are quite limited, and often only available in really specific contexts where there is a large LGBTQ community. But even that doesn't guarantee that it will be present. Even spaces like San Francisco have challenges addressing the needs of their older LGBTQ adults. And then the kind of, alternatives here, like mainstream support organizations, can also be risky or challenging. In the context that I'm in the US South, almost all of those are going to be faith-based, which could create, tensions for the client or patient. And then beyond that, just organization, you might experience individual staff or clients that might be non-affirming. So we have kind of an elder care organization that engages folks over age 50 for daytime activities. And one of the major complaints has not really been about the staff who've all been trained and done their diversity training and so on, but it's that the other clients who come are often not affirming. And it really doesn't take very many, right? Just that one experience with one client might kind of turn you off of participating with that organization for good. The last two things here, 10 and 11 here, are that folks who are currently in this older cohort are often aging without a partner, spouse, or adult children. That's not always true, but it's a much larger share than we would see in kind of the heterosexual population. They are more likely to have experienced rejection from their families earlier in life, and then older gay men especially are the most likely to live alone within this population. And finally, the support networks are going to look different. It's not that they're not there, it's that they look different. They come from communities, they come from friendships, chosen family, or partners, and tend to involve different folks, especially paid help, if that's available in an affirming context as well. Moving on to our objective 2, I'd like to kind of think a little bit more about how we can take that information and think about how to help enhance clinical and cultural competencies so that folks can provide respectful, inclusive, affirming care for LGBTQ seniors across healthcare settings. So what is this affirming care kind of language that I keep using? So in our present moment, maybe what you're thinking is kind of this really kind of specific conversation that we've been having at a national level, in states, in schools, in hospitals and healthcare providers about gender affirming care. But LGBTQ affirming care is kind of a bigger umbrella that we see that involves a number of cultural and clinical competencies. So these are things that providers and other healthcare professionals should be aware of and doing and thinking about in order to be respectful in their communication with LGBTQ individuals, to understand and address their health needs, and to really, convey that explicitly that this group of folks and these individuals are included and not excluded from receiving a high level of care. And so I'll give you a bunch of different examples of these, but essentially we're looking at these two different components, like understanding LGBTQ families, relationships, people, and how they fit into the world, as well as these clinical pieces, some of these healthcare disparities, health care issues, health disparities that I've relayed previously to you. So we can think about this happening at different levels. We can think about this happening between a patient and a provider. And here it might be really critical that the provider uses gender inclusive language or asks about pronouns. At my institution, the physicians and other staff very often wear a rainbow pin or sticker on their badge. But it could also mean, in the context of a patient encounter, sharing information about this increased and earlier risk of cognitive decline among LGBTQ older adults, right? This isn't like a diagnosis or a proclamation to the patient that, though, this is your fate, but more of a, this is a thing that is found in representative studies of people in the US, and there might be an increased risk here. Is potentially something we could pay attention to. At the institutional level, if we're thinking about like hospitals or practices, healthcare practices, we could think about implementing LGBTQ competencies in medical education. So there's a recurring review of how many hours physicians, for example, get exposed to LGBT-related content when they're in medical school. And that used to be about 5 hours on average. It's increased to about 11 hours, but over a 4-year period, people going through medical school only see LGBTQ content specifically addressed about 11 hours on average in the medical school curriculum. And so there are, a range of these studies that have also done this for nurses and for other specialties as well. There are also lots of opportunities for continuing education. You're in one right now, which is amazing. And, there's plenty of opportunities to just show up informally or formally for colleagues within an institution, even as an ally. And then at the structural level, here we're kind of thinking about like policy or things that are going on in your local environment beyond just your workplace. And you can think about advocating for health insurance expansion, coverage of gender affirming care, getting involved in this, in these debates, or at least understanding what's on the table here, and educating yourself about what the issues are. One of the projects that I've been leading to try to address some of these things and come up with other ways that we can measure the impacts of LGBTQ affirming care is through this project called VU Snaps. We've now renamed it Q Snaps, but it's the Social Networks Aging and Policy Study. And this study covers the US South. We've designed it to focus exclusively on LGBTQ plus older adults who are in midlife or later life, over aged 50, when we recruited them. And we've been talking to them since 2020 over multiple waves about their experiences with healthcare. And initially, we just asked them, do you have an LGBT affirming healthcare provider? And we gave them lots of opportunities to respond. Yes, this is somebody that I see as my primary healthcare provider. Yes, I see this person in addition to another healthcare provider, so like some kind of care fragmentation. But essentially, they're still receiving affirming healthcare services. No, I don't need or want this, or no, I can't find this kind of person. We also asked how far they had to go and how satisfied they were with some of the care that they were receiving. We linked this to their receipt of preventative screenings. So whether or not they'd seen a doctor or other healthcare provider in the past year, and whether they'd ever had any of the preventive care screenings that you see listed here, including flu shot, breast cancer screening, pap test, colorectal cancer screening, or HIV test, and if they'd had them in the last 3 years. We also asked about chronic disease management, especially things like mental health, high blood pressure, respiratory conditions. If they had reported a condition, we asked if these were still a problem or if they felt like they were under control. And our goal here was to try to see if there were differences in these outcomes, the preventative screenings and the chronic disease management, among people who said that yes, they had an LGBT affirming healthcare provider. And what did we find? So we found that in our sample of about 1,250 midlife and older LGBTQ adults in the US South, about 2/3 reported that their provider was LGBTQ affirming. And compared to participants with a usual source of care, so people who have a doctor, not people who are just going to the emergency room, but people who have a doctor that they didn't say that they said was not affirming, the people who had an LGBTQ affirming healthcare provider were more likely to be gay or lesbian instead of bisexual or something else. They were more likely to be transgender or gender diverse compared to cisgender folks. They were more likely to be living with HIV, which makes sense since they're kind of having a very different conversation about sexual health care in that context. And they're more likely to have a college degree or higher. So we saw affirming care access was structured by education, and they're more likely to be insured. When we look at these outcomes, we find that people with LGBT affirming healthcare providers were more likely to have seen a doctor in the last 12 months. They're more likely to have gotten a flu shot in the last 3 years, as well as an HIV test. And they were more likely to have ever had a colorectal cancer screening. This is a very challenging kind of marker to move because it's so invasive, because there's a lot of kind of social narrative around this particular screening because you have to be under anesthesia and so on. But we saw a 6 percentage point difference in colorectal cancer screening uptake among people with an LGBTQ affirming healthcare provider. And then when they had a mental health condition, they were more likely to say that it was under control when they had an LGBTQ healthcare provider as well. So we see substantial benefits in this preventative care space. What do we think some of those mechanisms are? Less avoidance. So patients might anticipate less discrimination, which could lower those barriers to engagement and decrease delays in care. So they just show up more readily and engage more openly with providers. They have more trust potentially. So affirming providers might engender more trust, increasing openness about problems and the patient's action on recommendations. And then additional mechanism could be that this care is more likely to be integrated. When you have an LGBTQ affirming provider as your primary provider, it's less likely that you need to go elsewhere to satisfy other specific needs, resulting in healthcare fragmentation. So the care that they're receiving is more integrated and thus can be more holistic and encompassing and efficient, effective. We've, since that kind of initial ask about who has an LGBTQ affirming healthcare provider and what are the outcomes that are associated with that, we've started looking into what kinds of experiences create an affirming environment. And we found in our sample that there's actually kind of 3 different groups of folks that are represented by the different color bars that you see on the screen. And the kinds of experiences that we asked about are listed on the left. So we asked first about kind of these really basic things that lots of providers have started to engage with, which include things like friendly materials or inclusive language. And that might be on intake forms or on websites or even just a marker for LGBTQ health on a website, right? And so we see the group that is in the darkest blue on the top very often report a feeling that they're the services that they're experiencing or receiving have those friendly materials. They have that inclusive language. We have another group that's sort of kind of getting some of that some of the time with the inclusive language. You see this bar of 40%, this kind of tealy bar in the middle, but it's quite low with friendly materials. This is kind of our neutral group that's not really getting affirming spaces, but not really getting discriminatory spaces either. And then as I go down, I'll show you these other kinds of instances that folks who kind of are reporting really discriminatory care are reporting much more often. In our affirming space, the next kind of set of experiences that folks have that we asked about was whether or not they felt comfortable discussing their care with their provider and their concerns were, and whether their concerns were addressed. And as you see in these bars, folks that are kind of getting this affirming care, as well as folks that are getting pretty neutral care. They're not really getting those affirming, inclusive kinds of languages or practices, but they are getting their concerns addressed. They are comfortable discussing their care. We see those green and blue bars like quite high all the way to the end. They're much lower for the group that we see in that third bar on the bottom of each section that we think about as discriminatory care. And that's kind of made clear by the next section, the third section, where those folks are also reporting higher rates of being asked invasive questions, that they're being told to seek care elsewhere, so that denial of care or like referral out because I just don't know how to treat you is kind of a response that folks get quite often, or that they needed to actually teach their clinician how to treat them, or issues or concerns about had concerns about their clinician's knowledge of the conditions that they were managing. So we see those three groups. And then across the states that we work in, another kind of key element here is that this is not distributed evenly, right? Access to LGBTQ affirming healthcare systems is not distributed evenly, including, more broadly in the US. So even within the South, we see pretty substantial differences between North Carolina and Tennessee in terms of just the number of LGBTQ affirming healthcare systems within the state. And if you're curious about this for your state or for the region that you live in, you can look up the LGBTQ Healthcare Equality Index, which has a big map nationwide to be able to show you kind of the differences in access by location. To sum up some of the takeaways from our research on LGBTQ affirming care, it's important, I think, to remember that currently not everyone has access to LGBTQ affirming care. We focused on midlife and older adults, and we see a pretty substantial group within our sample that doesn't have access to LGBTQ affirming care. And we see that without this, LGBTQ older adults are less likely to be up to date with preventive task force recommendations. We also note that patients in more affirming health systems report higher satisfaction with care overall, and this is not restricted to LGBTQ patients. So there is, an incentive for healthcare systems and practices to adopt more inclusive, affirming practices in order to increase patient satisfaction overall, not just among their LGBTQ patients. And we think that expanding access to LGBTQ affirming providers across the health system, across the United States, would help decrease healthcare avoidance and delay for LGBTQ populations, help us narrow these gaps that I've mentioned in terms of various conditions through timely screening, uptake of provider recommendations, and earlier detection of disease. And especially in the South, would help intervene in the poor health trajectories we see in many southern states for LGBTQ people. I want to spend a little bit of time to think about what providers can do specifically, given the clear benefits. Why aren't more providers LGBTQ affirming? This is a question kind of I had going into this. And then I realized after talking to lots and lots of them that actually they are. They just have very few, they feel unprepared, but people have very few reservations about caring for LGBTQ populations in most settings. The issues largely come from not knowing how to engage, kind of concerns about missteps or being, read as offensive, or not having the right kind of information, right, to engage with the more medical aspects of LGBTQ healthcare. And so we can fix those things. That's the upside of all of this. So we can increase awareness. We can by improving people's opportunities to attend trainings focused on LGBTQ health topics, knowing your workplace policies around LGBTQ inclusion and non-discrimination. You can join or start an LGBTQ allies affinity group at your workplace. Again, even informal participation here is really signaling quite a lot to some of the folks in this that you share spaces with. In terms of signaling to other patients or clients, folks have really been successful with adding a rainbow pin, lanyard, or badge sticker. But some of the things that we hear again and again from our survey respondents is that it's really like those help engage the conversation and decrease kind of barriers to having conversation. But even before that, right, a patient or client might be turned off by intake forms that aren't inclusive, right? So that don't allow appropriate identification of a same-sex spouse or, the patient's gender. Promotional materials that really just aren't inclusive of different family formations, or decorations around the office or website that are, signaling non-inclusiveness. Additionally, I've presented various times to folks, including one time recently in our Vanderbilt University Hospital's oncology and hematology department. And as I was walking up to deliver that talk with similar content on affirming care, I walked right under a banner that said the men's support group. And so very often folks who are non-binary or transgender or gender diverse have a challenging kind of engagement with these gendered program titles. They feel excluded or they're not sure if they're included, so they don't come. And so it's really worth considering whether we need to have that, whether it needs to be more specific, if it could be more inclusive. Are there opportunities to engage with folks where we're actually excluding folks, is kind of a consideration here, especially with gendered titles. And then finally, staying current by connecting with a local or national training program in LGBTQ health. There are many of these that we have some links throughout the slides that'll be in the PDFs to start getting there. If you've already done this kind of space, there are lots of ways to continually level up in the affirming care space. One of the most important, I think, is to continually check your assumptions. This is something I've worked in this space now for nearly 20 years, and it's something that I continually have to do when I engage with new folks. And the information and content and identities that folks have is constantly changing. And so I'm not always the most up-to-date person, so I just have to practice really often being humble, asking, being curious, as opposed to making assumptions or avoiding conflict and just not asking, right? We want to kind of engage that curiosity, engage that humility, and just ask. Additionally, we've heard a lot of reports from patients and other colleagues about the use of non-inclusive language in patient interactions that really just doesn't have to be there. So, for example, going in for a colonoscopy, a cisgender man is asked whether his wife is going to pick him up after the procedure, and he doesn't have a wife; he has a husband. And so using more inclusive language like spouse or partner, and again, just not making those assumptions, I think, and just really that day-to-day interaction signals quite a lot. And importantly, for people providing a range of different kinds of care to midlife and older LGBTQ adults, especially with cognitive impairment, I think it's important to pay attention to health disparity areas. So those other issues that I mentioned where there's higher risks, but also to pay attention to the whole person. So we see a lot of complaints about gender-related medical misattribution, or what's been called broken arm syndrome. Essentially, this idea that everything that's wrong that you're coming to get care for is really about you being trans or transitioning or hormones. It's not about, some other condition or disease that you might have. We see this also with body size, for example. People are often told that, oh, your problem is just your weight. Go lose some weight, and then we'll figure out what's really going on. And then lo and behold, we find out, oh, they've got actually stage 4 ovarian cancer, and they have like frequent complaints about pain that are very reasonable. And so there's this concern that this misattribution is happening, especially with transgender folks, but across the community as well. People experience and make complaints about invasive questioning, things that are, not relevant to the care at hand. That are being asked about, like, oh, when, how were elements of your transition or things like this when we're kind of going in for a foot surgery or something like this that's irrelevant. In many workplaces that deliver healthcare, it's very reasonable to just ask sexual orientation and gender identity and record it in the medical record. Many workplaces have a space for this, or can have a space for that if they toggle that option on, but many don't use it. Even here at Vanderbilt, when I look at those data, they're less than 1% complete for our hospital population. So people just need to ask. And then finally, you can openly engage care partners. I think this is critical. We've seen quite frequently that they're less likely to be engaged. With the information also that these are likely to be less traditional kinds of care partners, so not necessarily spouses, but might also be long-term close friends or community members that are integral to that patient or client's care. I've often been asked whether or not we really need to do this. Do I really need to spend time in this space and learn all this stuff and ask all these questions? And I think the answer is very resoundingly yes, right? If we saw this range of disparities in any other population, we'd have, a task force. But instead, we just have the people who continually get less poorer care, right? So we have 2.4 million Americans over age 65 that identify as LGBTQ. We know there are substantial disparities in disease risk, in diagnosis, in rates of recurrence and survival for cancer, even mortality. Increasingly, we know this for cognitive impairment and decline. And there's very good evidence that the care partners of LGBTQ older adults are being left behind. They're being excluded, they're being isolated, they're struggling. And you'll hear a little bit about that from Dr. Lampe as we go forward. You might also wonder whether patients really want to talk about this. Especially in the context that I'm in, physicians and other providers often say, well, I could ask that, but like patients don't want to talk about this. And so again, I look to the literature, and so there have been several studies. This is just one where they asked, nationally, whether LGBTQ individuals would feel comfortable reporting their sexual orientation and gender identity to healthcare providers. And resoundingly, the answer is yes. There are certainly concerns in specific healthcare settings for specific issues or with specific identities, right? Especially now, transgender folks may be more reluctant to share that information given the government that we have currently. But by and large, people are very open to sharing this information with healthcare providers because they know it creates better opportunities for care for them. If you need more information, I have a few links here that will be in the PDF, including those from the Alzheimer's Association, American Medical Association, the LGBT Cancer Network, and others that provide targeted resources around LGBT care in these spaces. Dr. Lampe.
Thank you, Dr. McKay. Would you like me to share my slides, or could I ask you to, I guess, project the slides for me? Oh, you're muted. Okay, I will project my slides now. Give me 1 second. Can I get a thumbs up from Pam or
Yes.
Dr. McKay? Okay, great.
Yeah.
All right, so hi everyone, I'm Dr. Nik Lampe. I'm the second presenter of this wonderful presentation. Dr. McKay threw a wealth of information at you all, everything you need to know about this topic of dementia care and caregiving and affirming care and why we provide affirming care for LGBT older adults and their family care partners. Today, I'm going to be talking to you all a little bit about identifying key concerns, but also strategies for care partners supporting LGBTQ plus older adults, including things like family dynamics, chosen families, and access to affirming care services. So, Dr. McKay and I have kind of thrown around this term of a role of family care partners or care partners. And what does that really mean? So we know the term family caregivers, but a lot of aging researchers and clinicians have kind of shifted towards this term of care partners or family care partners to talk about the idea of caregiving or care partnership as this, a more liberatory approach of not only accessing and receiving care, but also offering care too. And we know in the LGBT community that we're a part of that family care partners may include, but are not unlimited to things like partners or spouses, parents, siblings, or other immediate family members. But they can also be people in our life, what we term in research called chosen families or families of choice, who we consider to be family members, but may not be necessarily related to biologically or legally. So things like fellow LGBT community members, friends, neighbors, clergy or spiritual leaders, or perhaps clinicians, other members of one's chosen family. And so, as a kind of an attention check, I invite you all to kind of use the chat room. And if you feel comfortable sharing, who do you think is a part of your chosen family? What does your chosen family look like? And for everyone, that's different. And the reason why I'm asking you all this question is because I just want you to think about, this idea of chosen family and how we can use chosen families as a vehicle to eliminate dementia care and caregiving disparities among LGBT communities. And so I need to talk first to you all about key mechanisms for disparities in dementia care and caregiving for LGBTQ plus people. Dr. McKay had a fantastic overview on these key mechanisms broadly with care disparities, but I really want to hone in on dementia care and caregiving space in particular. So Dr. McKay mentioned how LGBT older adults are significantly less likely to be married or partnered, as well as significantly less likely to have children or kin compared to their heterosexual and cisgender counterparts. We also see this lack of LGBTQ plus non-discrimination protections, and specifically memory care clinics or other dementia care settings. We see instances where providers or staff maybe feel uncomfortable to include chosen family members in decision making for one's care. And this can provide a major barrier in having LGBT people have family care partners in the room advocating on their behalf when they're unable to on their own. Dr. McKay provided a wealth of information about limited provider training, so I'll skip that. But kind of building on Dr. McKay's point on this, we see this overall, this underrepresentation of research, clinical trials, and dementia care models that don't really give us a full breadth of what does it mean to be LGBT, and what does it mean to also be a family care partner or a care partner living with dementia. So what are the key concerns for family care partners of LGBT people living with dementia? So we see here that LGBTQ plus older adults and their care partners face substantial barriers in accessing LGBT social support and also accessing care for themselves as care partners. And so if anybody who's been a family care partner, or maybe you prefer the term family caregiver, you can probably think of times where maybe you had some significant health challenges, and that has kind of made it harder for you to provide care or to engage in care partnerships with your loved ones. But for LGBT people, this is a substantial disparity that I wanted to kind of dive into more quickly. So Dr. McKay and I had the privilege of publishing our research with QSNAPs and Alzheimer's and Dementia, the Journal of Alzheimer's Association. So we looked at specifically wave 3 of QSNAPs, and we really wanted to see who are these LGBTQ plus older caregivers for persons living with dementia, as well as those who are living with mild cognitive impairment. So mild cognitive impairment is a neurocognitive disorder that has symptoms similar to dementia, but may not be as severe. Sometimes clinicians talk about mild cognitive impairment as this transitional state between age-related cognitive decline. So we all lose cognition as we age. And then we've talked extensively about dementia. MCI may be seen as that in-between state, but it's a less severe version of a neurocognitive disorder with dementia. So we wanted to look at what are the experiences of LGBT older adult caregivers of persons living with MCI and dementia. What does their social support look like from family, friends, coworkers, and neighbors? And do they also are they able to access LGBT affirming care services environments? And so within our sample of about 1,000 respondents from QSNAPs, about 1 out of 12 respondents care for individuals living with MCI or dementia. And compared to other groups, MCI and dementia caregivers were more likely to be transgender, gender diverse, and more likely to report household income lower than the US median. We also see within this cohort of caregivers, they more frequently reported having unsupportive immediate family members, unsupportive neighbors, but report receiving practical help from others. And so when we're thinking about what does it mean to be a care partner for LGBT people, or maybe yourself are part of the LGBT community and you're also a care partner, these family dynamics or these caregiving responsibilities are a lot to kind of handle and deal with, and how do you try to get care for yourself, and how do you try to get care for your partners as well? And we also looked at LGBTQ plus affirming care access among the sample of caregivers. So dementia and MCI caregivers more frequently reported that they received healthcare in settings that did not display LGBTQ plus affirming materials, did not use gender inclusive or affirming language, or did not feel comfortable discussing aspects of their health and healthcare. So not only do we see disparities in accessing LGBT affirming care for LGBT seniors, but we also see it for caregivers of persons living with MCI and dementia. And I wanted to kind of focus on what are some strategies that care partners, doesn't necessarily have to be care partners of persons living dementia, but what are some strategies for care partners to kind of take away from this talk today? So we've kind of identified 3 main simple practical strategies for care partners of LGBT adults living dementia. And I'm going to just start with the first one. Use LGBTQ plus culturally responsive care language. And so Dr. McKay talked about the research and basically on the importance of providing culturally responsive or LGBT affirming language for care partners in clinical settings. But in terms of looking at the care partner in particular, it's always important to use person living with dementia's affirmed name, pronouns, or relationship terms. So what kind of terms do they want to use for themselves? And oftentimes that is a conversation to have, just to kind of establish a baseline of what would you like me to call you in front of the nurse? What would you like me to call you in front of your friends? Having clear expectations can be very important and save you headaches in the long run. Advocating for the person's care preferences and decisions. So let's say you're a care partner for your loved one who is transgender. They may want to be on hormone therapy services, and you may have to advocate for their behalf on continuing their hormone therapies to get the gender affirming care that they need, but also, trying to coordinate care in a way that, they get the memory care that they need, but also talking to providers about the importance of getting gender affirming and LGBT affirming care services. You may want to start encouraging early conversations about legal, medical, and identity related wishes to protect chosen family roles and preferences. I know a lot of people don't have access to advanced care planning services, things like healthcare power of attorney, and that is a disparity within our community. But there are a lot of resources out there that CaringKind and other national organizations can do to basically connect you with the right people to start thinking about those conversations. And I'm in Florida right now, and so we have areas of aging services that often connect folks in the community with those kind of resources on having a representative come in and help you talk through advanced care planning materials. And you don't necessarily need a lawyer for that. There are certain procedures that you just need to get, set to fill out stuff and notarize it and give it to your providers. Discuss how they want to be informed about their LGBTQ plus identity, relationships, or dementia status under one's circumstances. So I've talked to a lot of community members who are LGBT seniors over the years, and oftentimes, coming out or disclosing one's identity or relationship, it's very contextual. It depends on who you're talking to, what kind of environment you're in, and that's the same case for a dementia diagnosis. We see dementia stigma even in the LGBT community, especially working with gay and bisexual men, older men. We often see in researchers the idea of a lot of people having a fear of developing dementia over time, and how that can some people can assume that they also might have HIV. So there's HIV related stigma, all kinds of misconceptions in the LGBT community about what does it mean to live with and be a care partner for someone who's living with dementia. So just having those conversations early about what your identities, relationships, and dementia diagnosis disclosure experiences look like for you, look like in various situations, can just fully affirm the person's choices. And I would say a last point too, that as the person with dementia, develops dementia symptoms and at a more rapid pace, their memory, thinking, and behavioral changes can be substantially different from their normal memory, thinking, and behavior changes. So LGBT person living with dementia might have different views about what do they want to call themselves, or what their identities are in terms of LGBT people. So I've talked to a bunch of family caregivers of transgender older adults living with dementia, and they often get very confused about, okay, my loved one is calling herself by her old name when using her old pronouns. What do I do in that case? There's a lot of resources to help care partners through that. And I'm going to talk about that later in the talk. But the best thing to do overall is just, be open to the possibility of your loved one having different views about their LGBTQ plus identities, experiences, and relationships, even if it can be very hard and challenging, and try to remain supportive and non-judgmental in the process. And I know that's easier said than done, but it's not the person who is having these changes with their behavior or with how they view themselves and others. It's the health condition in terms of dementia. Dementia rapidly just changes your brain, and your behavior changes in a way that we can't control. So I wanted to kind of leave on that note. Yunette is a family care partner of her spouse who lives with dementia, and she talks about, how important it is to use proper pronouns in dementia care settings, especially in memory care settings at the more severe stage of dementia, because when you're dealing with stuff like end-of-life care or living with dementia in end-of-life care settings, it can be really off-putting and really harmful to be misgendered, to be named in various care settings. And the second point I wanted to make is the offering psychosocial support and assist with resource navigation. So as care partners, we often have to allocate and navigate various resources in order for our loved one to access them. So what does that look like? It looks like connecting with LGBT affirming age or dementia friendly support groups or providers. It looks like connecting with CaringKind and other caregiver support services organizations to get those kind of resources. They also have resources for insurance coverage and reducing financial barriers, as well as, supporting safe disclosure of care partner needs to assure affirming coordinated support. So being with your care partner living with dementia, hearing them out can go a long way in trying to, save the trouble of figuring out what they might need. Just ask them is usually the way to go. And the last point I wanted to make here is protecting your own health and quality of life. So oftentimes in dementia care research, caregiving research, we use the air mask on the plane analogy, where you have to provide air for yourself before you provide air for other passengers on the plane. So very similar. You want to protect your own health, stay healthy and resilient as family care partners, getting enough rest, getting enough, managing stress. These things can go a long way in protecting your health and also can help you provide better support for your loved one living with dementia. And I know we're running out of time soon, but I wanted to kind of talk more quickly about the policy implications for supporting LGBTQ+ seniors and their care partners. You all have a lively chat room about, some of the stuff that's going on in our political climate, but I would just say that, having non-discrimination protections is key here. Having more money, more other resources to provide LGBT affirming care, not only in healthcare settings, but specifically in older adult care settings, dementia care settings, palliative and hospice care settings, and also just protection of Medicaid, Medicare, and Social Security benefits, as well as, on the state level and the national level advocacy. So calling your lawmakers, telling them what you like or don't like about specific bills that may be harmful for the LGBT community in particular can go a long way. And so we do have a wealth of resources. Shout out to CaringKind for hosting this webinar, but I wanted to provide some supplementary resources if you wanted to kind of dive into. And the Alzheimer's Association is great because they have a 24/7 hotline in particular. So let's say you're a care partner and your loved one is having trouble with hallucinations, for example, and you need coaching from a master's level licensed clinician. The Alzheimer's Association has a 24/7 hotline that you can call anytime. And a master's level licensed clinician can help you walk through that. And other challenges, any kind of resources, or maybe you need a referral of providers. They have that information. They can connect you with your local chapter. All right, so that's it for me. Thank you for your engagement, and I'm looking forward to answering your questions with Dr. McKay.
Thank you so much. My goodness, what a wealth of information and experience and insights. Thank you so much. I know that people have been engaging in the chat, which has been fantastic. I'm going to take us off focus mode now, so people will be able to see each other. And I'm also going to allow people to unmute themselves. So if anyone has a question that they would like to ask, please feel free to unmute and ask. And I'm going to be looking in the chat here. Many thank yous coming through the chat. So thank you so much on that. And I know that there's been some back and forth about the federal funding being cut in
Yeah, just to be explicit. So the study that I mentioned that a lot of our data had come from, the SNAP study, was funded by the National Institute on Aging, from 2019 till February 28th. And was terminated under the executive order. We've sort of technically, as of last week, been reinstated, but not actually because the budget period ended. So a weird kind of like technicality. So we're ended. We were ended as of February 28th. Yeah. But we're, working with other potential foundations to try and maintain our cohort and follow up with folks. Certainly the work continues, both Dr. Lampe and I still have jobs. We still have work to do. We're still very invested. This is my career. I direct the LGBTQ plus policy lab. Like, this is the space that I live in, and, that's important to me. And so we're not going away, even though the dollars are not here. We still have all the data, and we'll find new projects and other ways to, keep our time, being helpful.
Thank you. And I believe Lauren put something in the chat if people want to make their voices heard, and reaching out to, I believe, government officials. Yeah. There's a link there.
Yes, and it gives you scripts and everything. So you just put in the topic that you care about, whether it's this topic, other forms of healthcare, gun violence, really, whatever. And it provides the script, guys, and the phone numbers, so you can really call those people and start hounding them.
Thank you. Thank you. I'm scrolling for other questions. And thank you for all of those resources. I know SAGE is someone from RVP Social Services said that they have SAGE competency training every year, which is a wonderful training.
I would mention that, we were trying to make sure that folks are aware of, concerns or differences or issues that might need to be addressed in healthcare settings. And we have, both Dr. Lampe and I have heard so many, case, interviews and cases with folks where, something really unpleasant, or, borderline illegal happened in the context of healthcare that really shouldn't have ever happened. That was discriminatory. And so, we're trying to highlight those kinds of things to head them off, because it's really important. And also, a lot of the folks that we work with and the participants that we interview are really living fulfilling, engaged community, integrated lives, that they celebrate, that we celebrate. And so it's not all bad news. We, have a lot to celebrate in the community, and people care for one another, and that really shows. I would just say a lot of the things that we mentioned, at the margins, right, are people struggle at the margins and maybe don't have access to all of those things, especially if they don't have a care partner, they don't have access to healthcare that is going to validate and, treat them with dignity.
And thank you. And I know both of you do work in different spaces, and I wonder if you can share anything about intersectionality around LGBTQ plus and African American or Latino. Are there special considerations there, or anything that you would want us care providers to know about intersectionality?
Yeah, absolutely. I think, a lot of if you take apart the LGBTQ plus, right, a lot of different groups are experiencing different kinds of, microaggressions or discrimination or hostility, and that might also be impacted by the settings that they're, receiving care from, and or the opportunities that they're able to receive care from. And there's a lot of differences by race, by education and income, by just location. Rurality is kind of a big predictor of access to some of these more inclusive services. but I think some of the assumptions here, right? Like, so we see very often like there's a lot of concern about rural areas, LGBT people in rural areas having just poor experiences overall. And some of our research shows that actually they are part of very tight-knit communities. They receive a lot of help and support. They do also experience different kinds of discrimination, but they, are often there intentionally. And with other community that they've really invested in. And so they do have different supports and strengths that can be mobilized in some of these settings, and that, can be invested in by organizations or be scaled up, right, to other spaces. Did you want to add based on some of
Yes.
that work?
Yep. I, doing this kind of work, I think, the what I tell every clinician or service rep is if you meet one trans person, you meet one trans person. If you meet one, under the alphabet umbrella person, in the LGBT community, you meet one person. And I'm just thinking about like, for example, I work very closely with the Acts 2 project, which is the Black Dementia Caregiver program in Florida. And they heavily rely on faith affirming spaces, especially faith-based communities. And so, the work that I have kind of done through them with Black LGBT communities is you can't really have a community event without involvement from faith-based leaders and community settings, and that's just a part of the community setting, a part of the cultures that we hold. And just because we have one identity doesn't mean it's this fixed category. There's multiple parts. And so and I'm also kind of thinking too about community members that I've talked to who are LGBT seniors talked about how they like it, they really love it when providers have affirming language, use their name and pronouns, but that's not everything that they want. They want someone who is provides patient-centered care, is compassionate, empathetic, listens, is respectful, even if they maybe have disagreement with politics or service settings. But it's very easy actually to be an affirming care provider just by listening to your patients, hearing them out, understanding where they're trying to understand where they're coming from and being respectful. That just goes a long way. We don't have to be experts at LGBT affirming care to provide it. That's just part of the basic principles of patient-centered care. So that's kind of the thoughts that came to mind for me.
Thank you so much. And the humility that you talked about before, Dr. McKay, that we may be knowledgeable about certain things or experts at certain things, but we're all humans at the end of the day and prone to making mistakes, and just being able to be human with another human in an empathic and real way goes such a long way. So thank you for
Absolutely.
that.
And we're all learning and updating in real time. And brains are funny. We had a presentation by someone who works, who studies kind of language processing and development in the brain, come and talk about what happens when, you have to engage with different pronouns than you assume, match someone's gender. It's actually very hard for your brain to do both like verbally and in written, like whether you're reading it or writing it, right? Your brain's using different sources. And so we make mistakes and it happens. And you say, I'm so sorry, and you fix it. Hope that we can, kind of engage in that, like in a way that doesn't have to make assumptions, right? Doesn't have to avoid it, right? Just because it feels hard. I think that's really important. Also the same with like relationships, right? Making assumptions about what kinds of relationships people are in, as opposed to kind of letting them talk about it and use the language that they want to use for that.
Thank you so much. We are getting to time, so I want to quickly, in case people have to jump off right at 4:30, want to encourage people, please, we put a link to a survey That is also what allows you to get a certificate of attendance or your CEUs. But even if you're not interested in either of those things, we ask that you complete our survey. It's really helpful to have feedback, especially for our funders. The Hearst Foundation has been generous in providing grants that allow us to offer these programs. So please do take a moment. It's pretty quick, simple survey, but please do take a moment to fill that out. And we'll also get an email with a link to the survey as well, in case you're not able to access your chat right now. Any last pressing questions or thoughts before we bring this to an end? We're getting more gratitude.
Yeah,
in
it's so
chat,
amazing.
so-
Thank you all for attending and being a engaged audience. Really appreciate it.
And thank you both so much for coming and sharing your experience and wisdom with us. This was a really, really fruitful 90 minutes. It went so quickly.
Yes, thank you for inviting us. It was fun.
Right, everyone. Well, we thank you so much for coming and spending the afternoon with us. And thank you so much for being a part of our CaringKind community. Please keep in touch with us. You have our helpline. Please make referrals and come to future education programs as well. Thank you, everyone. Have a wonderful day and afternoon.
Thank you.
Thank you.
Bye.